Everybody to the Skilled Nursing Facility or SNF CB Billing Modifier TC and 26 webinar. This webinar is designed for one area within SNF Consolidated Billing, again SNF CB. That area is only if you're working with modifier TC and 26. All other SNF Consolidated Billing questions that were asked will be posted at the end or will be answered at the end. Okay. Um, I'm Tom Ryan. I'll be your presenter, and today I'm joined by Leanne. She's from my team. What are we here for today? Today, we're here to help you look at services that must be split billed. One component goes to Medicare, and the other component goes to the Skilled Nursing Facility Consolidated Billing. These are diagnostic services or other services that would have a modifier TC and 26. You cannot global bill them for some purposes. So we want to be able to know, hey, what are the purposes? When do we get to bill one? Where does it go? Or when do we have to bill two and why? So we'll talk a little bit about that. I will provide an overview of SNF, which is Skilled Nursing Facility CB or Consolidated Billing, so SNF CB. The reason that we do that is that we do have some people that are new to Medicare, and we do have probably about 5 to 10 of you that registered, but in particular I have one of you who this is your second week, so welcome to Medicare. This is a complex topic. I will stop after the overview and just take some questions for that purpose. We're then going to look at professional versus technical billing and making sure that you get those to the right place. We'll also then continue on and move to the CMS files and how do you know which codes do you have to split bill? Which codes do you have to split bill? Keep in mind, again, when I say split bill, what I am saying is that you will bill one component to Medicare and the other component to the skilled nursing facility. Split bill it. All right, here we go. So as I promised, I do want to start with an overview. This is a high-level overview. So after this, if you are one of the people that is new and you have questions, I'm going to stop and take some questions on here. If you just want to review or there's something that you're wondering about it, great, but remember that we're not going to get into all the detailed components of the different files. We're really going to focus just on the modifier 26 and TC. So what is Skilled Nursing Facility Consolidated Billing or SNF CB? SNF CB is a bundle. And what that bundling does is it says that the SNF is responsible for most care provided to an inpatient in a skilled nursing facility as long as Medicare is covering that stay. Now, what that means is Medicare making a Part A inpatient payment or coverage decision? It could be going to deductible as well. If that's happening, then it's considered a covered Part A stay. If they are in a medically necessary stay, but Medicare Part A is saying, nope, you're out of benefits, you don't have any more, or nope, you didn't meet one of the qualifying criteria, which we will get into in just a few moments, then that is considered a Part B stay. Again, it's still a stay, it's still inpatient care, it's just that Medicare isn't paying for the inpatient portion, which is the room, the bed, those types of things. All right, so when it is a medically necessary inpatient stay, the bundling occurs. That bundling's name is Consolidated Billing or SNF Consolidated Billing, SNF CB. So, what does this mean? Well, first, the goal was to make sure that the SNF who is overseeing the patient's care knows about all care going on with that patient. They're coordinating the care, they're overseeing it. The next goal was to lessen the patient's out of pocket. So instead of receiving care and then getting a bill from the SNF, you're receiving care and getting a bill from the SNF plus a lab plus this plus this plus this. CMS decided to consolidate that and to make it less confusing for the patient, and it will also then reduce their out-of-pocket. And the last part, it eliminates duplicate billing. Someone can't bill us from the facility side, but then turn around and a professional can't bill us for the same service. That's what the consolidation does, is it looks at all of those. So that's why Medicare put it in place. In other words, the ultimate goal to go back to where the patient is inpatient at, and in this case, it's a skilled nursing facility, and to have them coordinate, oversee, and pay the care that they're responsible for. With that said, part of consolidated billing is excluded services, and we'll talk about that when we talk about the two types of exclusions coming up. What are SNF stays? And I've already described these, but I want you to know that I did put a slide in here. There was a question that came in, and it's related to the second type of stay, which we'll talk about in just a moment. There is what is called a Part A stay, and I want you to know to note the word stay means inpatient. Medicare is covering the inpatient stay. The room, board, nursing care, etc. is all part of that. Anything that's within the scope of a skilled nursing facility will be incorporated into that bundled payment. For each benefit period, we'll get to that in a moment, there is 100 skilled nursing facility inpatient days. Once that 100 days is gone, it's all used up, then the patient becomes responsible for the inpatient care unless Part B would cover it. Now, Part B is outpatient, Part B is professional services, Part B is supplier, such as labs. So unless Part B covers it, hopefully that makes sense. In this case, we then move on and we move to a Part B covered stay. So, okay, what does that mean? It means that Medicare Part B can pay for things. That does not affect how it's billed, right? The billing is done differently. So if a skilled nursing facility wants to learn how to bill, we have a series of classes on that. That's not this course. Okay. But we want to make sure that you're aware of it. Why do you need to be aware of a Part A stay versus a Part B stay? Because for most people, most professionals, most services, including supplier services such as labs, ambulance, if they're in a Part B state, none of that is billable to the SNF because the SNF is not getting paid for that. The exception is the SNF is always paid for physical, occupational, and speech language pathology. That's part of the rehabilitation services. That's what the patient is in the skilled nursing facility in a medically necessary stay for. And because of that, even in a Part B stay, those services must be billed to the SNF. So Part A stay, we'll talk more about determining that when we get to the files. Part B stay, only PT, OT, and SLP. In this case, because this is about Modifier 26 and Modifier TC, that will not apply. All right. So hopefully that makes sense for the two types of stays. One of the questions that we got is, does the skilled nursing facility have a deductible that can be applied to theirs? And the answer is yes, they do. Remember, each Medicare inpatient stay has a deductible. It's measured in a benefit period, and that means the first so many days apply to the deductible. Once that deductible is met, then it just moves on, and then we go to the copay days. Now, for a skilled nursing facility, it's 20 full pay or deductible. So if the deductible is not met, they must meet that. Then it's 80 copay days, so 2080. We'll talk a little bit more about some of those different types of things that you might want to be aware of. All right. A couple people asked about excluded services, and I wasn't entirely sure. Oops, did I skip a slide here? Oh, yep, this is crazy. There we go. A couple of people did ask about excluded services, and because I wasn't sure what type of excluded services, I put this slide in. And I want to first start off with Medicare recognizes two types of excluded services for a skilled nursing facility stay. There is Medicare excluded services. These are excluded by law and are never covered under the Medicare program. Those are always billed directly to the patient, and they are the patient's responsibility. It does not matter if you are a skilled nursing facility, an outside entity from the skilled nursing facility providing a service, none of that matters. Also, we had a question come in about excluded services that are medically necessary. Excluded services are, again, excluded based on the law, not based on medical necessity. Therefore, they are the patient's responsibility. Keep in mind, this is different than a SNF CB excluded service, Consolidated Billing excluded service. What the SNF Consolidated Billing excluded services says That service, that procedure code that you are billing is not within the scope of a skilled nursing facility. Therefore, you should bill Medicare directly, unless that service is completely excluded from Medicare, in which case you'll bill the patient. That's why it gets a little bit confusing and why I wasn't sure which type of excluded service you were talking about. If it is a SNF consolidated billing excluded service, which is a lot of what we'll focus on today, it simply means bill Medicare directly. If it's a Medicare excluded service, then you'll bill the patients. Again, if you have more questions or need a bit more information on that, if you could provide me some more information in the chat, I might be able to help you more. But the question was really vague and I wasn't really sure where you were trying to go with it. So hopefully that gives you what you need on that. Okay, so that is really about making sure we get to the billing. A couple of things to keep in mind. The patient liability can be assigned while in a skilled nursing facility stay. It is assigned to services that are excluded from SNF consolidated billing. That was a question that was asked. It's not anything related to billing or anything like that. It's just patient eligibility is. Okay. When we look at that, we also want to address a couple of other things with it, but I do, which will come in the next section, the billing section. So I do want to stop there and just ask Leanne, do we have any questions that are happen to be in the chat?
Tom, we did get one question in the chat, and the question is asking, how do we find out if the beneficiary is currently in a SNF? I do not recall eligibility telling this, only hospice.
Good question. And well, it doesn't directly say they're in a skilled nursing facility. There is a portion of eligibility that does offer that, but there's some caveats that go with it. So what I'd like to do is move to the WPS website and I'll show you where you can find that because it is in our portal section. So give me 1 second while I flip up. There we go. And again, can you verify that you are seeing the website?
We are.
Okay. On the website, you'll see this section up here and it has the unique username, password, login, that type of thing right here. Username, password. If you log into this, you'll be taken into what's called SNAP, the Secure Net Access Portal. I call it the portal, so you'll hear me use the portal all kinds. But what happens is once you're in the portal, what do you look for? That's what I use the portal user manual for. Now we do have classes on this. If you're on our YouTube channel, take a look at our encore presentations. We have full classes that explain all of this. So my kind of summary will get you what you need, but I would recommend taking a look at YouTube and if you do have further questions. When you look in the portal, what I want you to do is follow down through. If you want to open the full manual in a PDF version, use the download up here. If not, scroll down. And if you don't like a fast scroll, please look away at this point. I'll tell you when to look back. I'm scrolling down and I'm going to hit this section called patient. So you can look back now. You'll see the term patient. Underneath patient, you have two tools, the beneficiary, which is the MBI lookup, or the eligibility. We want eligibility in this case. Once I select eligibility, it's going to explain the source data. And the source data is the HIPAA Electronic Transaction System, or HETS 270-271 transaction. One thing to keep in mind, this is done through this transaction. It is done through the common working file, and then that is where the information comes from. Now, HETS, the HIPAA eligibility transaction, brings all kinds of things together. All kinds of things together. So while we do have a Medicare eligibility system, which is done by either the Railroad Retirement Board or the Social Security, we also have Part C or Medicare Advantage eligibility. So in order to bring all that together, that's why it uses the common working file. It's like a communication storage system. It's really what it is. Some people call it a communication hub. It's just different terminologies to the same thing. What you're going to do is you're going to look and you're going to scroll down and you're going to say, I want to do accessing eligibility. That's what it looks like. You keep scrolling down. You have to enter the fields. When the data displays, you're going to have two options, supplemental insurance or eligibility. You will default to eligibility and you want to stay there. You want to stay there. It's going to give you your patient information. Again, look away if you don't like to scroll, but I have to scroll to get you through stuff. The first thing that's going to happen is it's going to give you a summary of the benefits. That's going to be a dark blue box or a dark box that you'll see with the word summary in white. Then you'll see white boxes with dark writing. That's like the Part A, the Part B. So if we read through this summary, we can find out some different information, but what we're really looking for is this Part A deductible button. I'm going to keep scrolling down and we're going to move to that. And what you're looking for are this bottom three fields, which is the SNF spell dates when they're in. Again, if deductible is remaining, may not be, could have all been met in the hospital stay, don't know about that. Then copay days and copay days remaining, and then SNF day and the billing NPI. This, if that helps, is what you're looking for, those three fields. So hopefully that helps you get what you need there. That's how you'll know the SNF. Now again, sometimes you're gonna have a billing NPI and you have to take that to NPES or to look it up. That's also just how it works. So hopefully that answers the question. Leanne, any other questions?
There are no other questions in the chat, Tom.
All right. So with that said, this is a very high level overview. Hopefully I didn't lose anybody and everybody's right with me. Let's go ahead and move on to billing. And what do you have to do in order to get things billed correctly? First, you have to determine whether a patient has Medicare Part A and B coverage. So remember when I said, hey, here's this summary information back on that screen? There are also dates. The effective dates are available. The question was, why wouldn't someone have Part A coverage? The answer is not everyone has Part A for free. For those that did not work at least 40 quarters in a lifetime or have someone else that did that they're eligible under, there is a premium and the premium is very high. So they may elect not to pay that premium, which means they would have Part B coverage, which means SNF consolidated billing does not apply. So hopefully everyone understands that, the reason for that, things like that. On the other hand, you could choose not to have Part B. You could simply say, I don't want to pay the premium for Part B because everyone pays a premium for Part B. And if you can't afford the premium or you choose not to pay the premium, you would not have Part B. So you might have Part A because it's free. You worked over 40 quarters in a lifetime, but you choose not to have Part B. You might have Part B, but you choose not to have Part A. That's how it works. There's also, if you look, called the Medicare Advantage plans. You must check to make sure a patient is on traditional fee-for-service, Part A and B Medicare, and they do not have a Medicare Advantage plan. Again, that's in the eligibility system. And remember when I said, okay, you're going to give your basic summary, then you're going to have your Part A deductible, your Part B deductible. There's an actual button called MA, and that's for Part C or Medicare Advantage plans. And you'll need to look there. If they have an active Medicare Advantage plan, SNF consolidated billing doesn't apply, does not apply, because you would bill the Advantage plan and you have to follow their rules, which may not be the same. The last thing that you want to look for is someone that does have Medicare Part A and B. However, at this point, they are incarcerated. Therefore, their Medicare benefits have been stopped for a period of time. That period of time is while they are incarcerated, the governing body must pay for that unless they charge everybody for the services, not Medicare people, not just, people that don't have it. It has to be across the board. Then you would follow the consolidated billing rules, and you may need to incorporate a modifier QJ to indicate, hey, yeah, we know they're incarcerated, but guess what? You still need to pay it because it's excluded from Medicare or from SNF consolidated billing, and they're required to pay it. So a lot that went into checking that eligibility to determine whether you should be a skilled nursing facility or Medicare, right? Do they have Part A coverage? Do they have Part B coverage? Are they incarcerated, or do they have a Medicare Advantage plan? If they have Medicare Part A and B, then we fall to the consolidated billing. If they're missing a part of it, then nope, we don't do that. If they're incarcerated, there's no billing at this point to Medicare unless, okay, so did we hopefully get all of that? If not, throw some more questions in. The next item that Medicare requires is that a service has to be medically necessary. It cannot be part of the excluded services list, and it also has to meet certain procedure codes to be based on the file to look up. So that means you have to be able to say, yes, the service was medically necessary. The medical record must support that. If a skilled nursing facility asks you for a medical record to support that, it's because Medicare is asking them for a medical record to support their services. And guess what? They have to supply your medical record as well because they're billing for your services. It's part of their payment. So it's not a HIPAA violation to give it to them because of the way CMS requires it. Okay, so medical necessity is absolutely something that has to be there. Now, could a skilled nursing facility have a patient in a bed that is both Medicare, Medicaid certified, but also both um, that is not necessarily about skilled care, right? So the patient's in it, but they're not in medically necessary stay. That's fine. That service would be excluded from consolidated billing because the SNF can't bill that service anymore. They have to bill us in a certain manner to say, yeah, we still have them, only it's not medically necessary anymore. In which case, it should end the consolidated billing at its hitting. So you would simply bill Medicare. Next, you've got excluded services. We talked about those. And then you do have to ask for procedure codes because, again, the procedure code, and by the way, when I say ask, it's not like you're asking the SNF for it. What you're doing is asking a coder to review the medical record to determine what procedure code would be billed, to determine whether or not that would need to be split billed with the modifier 26 and TC. That's why I'm saying to ask, get your procedure code so you know if you should, when you look at the CMS file, who should get that bill. So that's what you're asking. Now, some of you may say, hey, I'm the coder, but guess what? I get to do the billing too. Well, then you don't have to ask because you're going to know and we'll teach you how to look that up. All right. A few people did ask us about not affected facilities. Critical access hospitals, you guys have an exception because of how you're paid. Your swing beds are not subjected to consolidated billing. However, they are subjected to hospital inpatient bundling. So again, a little bit different there. Also, critical access hospitals performing services not related to, so maybe they're doing a reference lab service or something like that. You are part of consolidated billing for that, which is why the modifier in 26 and TC may apply to your service because you're doing it as a reference lab versus something else. So hopefully that makes sense. Um, Rural health clinics, you're not affected. Your payment methodology is different, so it does affect things differently. Federally qualified healthcare centers, same thing. Federally qualified health centers, it's the same concept. Your payment methodology is different. Medicare excluded services, never affected, period. It's not on the CMS list of excluded services, then it's probably not affected, especially if it's bleh, if it's not outside the scope, because there are certain ways and caveats that go with it. And that's why we say not on the list, because, oh, wait, now we have to have it affected because it's on this list. And by the way, you got this, this, and this that go with it. All of that's what we're going to get a little bit more into. Okay. The consolidated billing basics. So first, there are procedure code files. Each procedure code file is divided. Well, I should say there's two sets of files. One is Part A files, which are UBO for inpatient files, and one is Part B files. So you could be a Part B service during an inpatient stay, which is what a reference lab could be as an example. These files are then updated annually and posted to the CMS website. So we do have to check a couple of files when we go to look at it. We have to look at the Part A files and the Part B files. And that's literally labeled on the CMS website in that way. So if you're wondering why I'm using those terms, that's where it comes from. Okay. What happens is when you're looking at these two files, some services for laboratory or some services that have a professional technical component will be on both files. So we're going to talk about what that means in just a little while when we get to the files and actually explore them. The billing guidelines. You still have to follow the Medicare billing guidelines if you are billing Medicare directly. That doesn't change. Those are for services that are excluded. So for instance, are you billing a professional service? How do you bill that professional service? Do you bill it on a UBO4 or do you bill it on a 1500? Do you bill it on the 837I or the 837P? All of those guidelines still apply. On the other hand, The skilled nursing facility, when it is an included service, including the technical component, they will tell you how they need it billed and what information they need. This can vary. Some skilled nursing facilities are like, you know what, just go ahead and give us that 1500. Some are like, no, no, we want it on a UB. Others are like, no, no, just send us an invoice. That's all up to them. They do have certain things that they must have, though. That's why they have to determine what's best for them from their business practice. So CMS does say if it's ours, you got to follow our guideline. All right. If it's not ours, then you got to follow whatever the facility, skilled nursing facility that a person is in, you have to follow their guidelines. So if it's included, you want to make sure you do that. Let's take a break. Let's stop for a second before we move to actually locating and reading the CMS files and see if there are any questions.
Tom, we do not have any questions in the chat.
Okay, so here comes a really important part. For those of you that are listening, you may want to grab your computer. You may want to be at your computer and kind of navigating with what I'm going to say. Hopefully it will help you. Okay, so I just want to make that aware. The first thing we're going to do is we're going to move to the CMS website and we're going to look at how to locate the two sets of files, which is what the slide 16 is all about. It's actually going to show you the files. I'm just going to do it live on the CMS website because I think it's a little bit easier for me. So, CMS website, cms.gov. Once you're on cms.gov, the first thing you have to do is know that you are looking for Medicare. Medicare is in the upper portion. It's got a drop down with it. When you select the drop down or the little caret, Medicare, however you want to get this open, now you have to look at the left side and you'll see a variety of options followed by little carets. The option you're looking for is coding and billing with a little arrow pointing to the right. If you select coding and billing, a new screen will open on the right. And if you go to the far right column, the second item down is skilled nursing facility consolidated billing. Once you open that up, you will be in a general overview set of information, and this is what it looks like. Just some really basic stuff. It's got some nice resources down below if you want to take a look at those. But what we're looking at, and the reason that I want to make sure I scroll just a little bit here, you're looking at the file update. This is the Part B files. This is the Part A files. They're both related to inpatient care, and their files are then labeled. I will recommend that you always start with the Part A file. So if the patient does meet the Part A coverage criteria, this means they've had their 3-day inpatient qualifying stay in a hospital before entering the skilled nursing facility. That stay must be within 30 days unless planned otherwise and documented as planned otherwise. If those two are met, then we will consider, and I'll talk more about that. I have a question that came up on that, so we'll get to that one at the end of the webinar. So let's go ahead and take a look at this set of files. First, somebody asked about this update. Sorry, give me 1 second. Somebody asked about this update information and if you need to know it. Yes, because remember the files are only updated once a year, so the CMS may put other changes that happen or things that they may have missed or whatever happened within it. So you want to make sure you just read through that. Then if you scroll down, you'll see two files down here. One is a zipped file, and this will contain the actual Excel document. The other one is the explanation of the files. I'm always going to encourage you to start with the explanation if you're not familiar with the files. Explanation isn't a PDF, and this is the exact PDF. Okay. So what we're looking for is, okay, if we're going through this, what are we talking about? Well, it could be any of these that would be broken into a professional and a technical component. Okay? And it's usually going to fall into the major category one for the exclusion, and it's whether or not the technical component should be billed to the skilled nursing facility. We'll learn more about that on the next set of files. But what are you looking for? And if you read the caveats, there's a lot of information on this one. I just want to point out a couple of things here. These services must be provided on an outpatient basis at a hospital, including a critical access hospital, but not by a SNF. So if it's not at a hospital setting, so if it's an independent diagnostic facility, then they are included with it. If they're not and they're in this, then they could be excluded, including certain caveats that would go with certain procedure codes. So an MRI, and then the reading of the MRI, they would both be excluded if the MRI was done in a hospital or a critical access hospital, if it was done in a freestanding diagnostic center or maybe a mobile MRI unit, not excluded. So that's where we have to kind of come in and read through these different things. Okay. So we read it, but what does all of that really mean? All right. Well, what that means is now you have to open up another file. And that file is this, which, sorry, I forgot, is this file, which I remember I talked about it. That looks like this. This is just the zip file, and you want the Excel version. You can open up either one you want. I like the Excel version. So once we open up the Excel file, we get a list, and you can see these major categories. All right, so then you got to have a procedure code. How does it fit into the major category? That's what we're looking for. This is why you needed the procedure code, why someone needed to code it to be able to tell you what's going on with it. And you can just see, as I'm scrolling through these, there's just a lot of CT scans. That's major category 1A. If I just jump ahead a little bit, you'll see 1C is an MRI. The caveat is even if you're doing a professional and technical component, if it is at a hospital or critical access hospital and it's on this list, then this would be billed directly to Medicare. If it's not on this list and you're doing it at a free, or if it is on this list but it's still at a freestanding facility, then it's the SNF's responsibility for that technical component. Hopefully that does make sense to everybody. The next part that we need to look at is what happens when we look at the Part B files. Now, Part B files are commonly used for professional services. So we're going to scroll back to the top and we're going to pick the most current Part B files. Unlike the other one, there are 4 distinct files. The other one being the Part A files, this is the Part B files. Again, what's not different, the additions, changes, and deletions is published once a year. Anything in the in-between, you want to make sure you read this page and scroll down. Okay. You have 2 sets of files. Part A stay, physician services. Wait, Part A stay, physician. Wait, isn't this the same thing? And the answer is no. These are always excluded. These are the split bill files where the physician service is excluded. It's not talking about the technical component, it's talking about the modifier 26 component. If you're wondering why I'm still talking about that just a little bit, I'm stalling. There we go. Stalling for this to open so that I can show you this file and again have you open the Excel, which is much easier to read and looks like this. But I do want to point out this portion right here in the top. Part A state professional components to be submitted with modifier 26. That means you must submit these to Medicare with the modifier 26 appended. If they do not have a modifier 26 appended, Medicare can deny them because now you are submitting a global charge for both a professional and a technical, and Medicare is not able to pay that. What we're saying is, hey, this is just the 26. The professional component needs to go over here, except in this case, oh my gosh. So we're not getting into that. We're going to focus on the modifier 26. This is when you need to bill it to Medicare. So anything on here, you'll append to Medicare with a modifier 26. Remember, the skilled nursing facility is not responsible for the interpretation or the reading or that professional component of a test. So that's why there's 2 separate files, and hopefully that does make sense. One of the ones that I like to use just to show you guys, I'm going to use an MRI code because this is the easiest one for me. I'm going to go ahead and look it up here. So I'm just going to hit Control and F, which is the Edit Find feature. And I'm going to paste within that 70540, hit Next. This tells us that if you're doing the professional component, yes, that is billable to Medicare. That is billable to Medicare with a modifier 26. If we go to the other file, which is the one with all these major categories, and we again use the Control and F on this one, and we use the same exact code, it's on there as well. So what are the caveats? Well, the professional component automatically exclude that bill out to Medicare. The technical component, we find out it's in major category 1. So if we're not really understanding that, remember we got to come back here, scroll down, and we're going to read the general explanation again. We're going to read about major category 1. We know it was an MRI, so we know it's going to be in the subcategory C. But what do we know about major category 1? Where was this performed at? Was it in a hospital or critical access hospital? Then you will bill it to Medicare. If this was performed in any other setting, then it will be billed to the skilled nursing facility and will become a portion of their bill. Okay? Hopefully all of that makes sense. I know it was a bit convoluted when you get into those two modifiers and how they work together. So remember, if it's on both slides, that's where you're at. I will let you know that I did move through a variety of slides, and hopefully you were following along as I went through. We went through the updates, the subcategories. We talked about the file explained. We then moved on to file 2 and the Part B files. We talked about that, showed you the header up on the top. We then moved on to a little bit more of information on how to read it. Talked a little bit about that. We looked at the code that was on both of them. This is the 70540. How to build those and how to make sure they're getting billed correctly. Which leads us to the question and answer session. What I'd like to do now is just provide you guys with a few question and answers that were pre-submitted, and then we'll move to anything in the chat. So first, they're looking for more information on when to use the TC modifier. Do we use it if one provider orders the procedure, example a CT scan, and another provider reads it? The answer is possibly. Can you tell me who performed it? So if in this case, let's just use the CT scan because that's what was in particular the question looked at it. The TC is not used on the ordering provider's claim. They ordered it. It's written as an order as part of an office visit, as part of a diagnostic, whatever they're doing. There's some reason that they're ordering it, but it's not necessarily the scan. The scan then has two components. One, someone has to run the CT scan. That is a technical component. Yes, there's a person there running the actual scanner, but that's not, the person's not getting paid. The second component is the interpretation of the scan. What does it mean? What does it equal to? That is the professional component, which is 26. So in this case, you take that TC modifier component and you say, should it be billed to Medicare or should it be billed to the skilled nursing facility consolidated billing? The answer for that is go back to the major category, major category 1. You have a caveat for CT scans, so I do have to know the procedure code. Once I get the procedure code, I come in and I check and say, okay, yes, it's on the list. Now I have to know whether or not the CT scan was done in a hospital or a critical access hospital, which is just a form of a hospital. If it is, you bill Medicare. If it wasn't, you bill a skilled nursing facility for the technical component. Then you take that same code and you want to find out if modifier 26 should be billed to Medicare. And that's where you leave this general explanation stuff. And you're going to go to these Part B files way up here on the top. Then you have to go to file 2 on the bottom. And is it on there? Now, for the most part, it will be. And that means you got to separately bill them. Now, if you say, hey, guess what? They're both separately billable because it was done in a hospital and the hospital is providing the professional component. You can globally bill that as well. The hospital could do that because it doesn't need to be split billed. We're saying, hey, it doesn't need to be done. The hospital did all of it. Hopefully that all makes sense based on the question. If not, feel free to put that question back into the chat or ask additional questions to support it. Again, I want to run over this part again, and it's coming back to our website because the question relates to how to make sure that I'm double checking what the best resource to determine whether or not they're in a skilled nursing facility stay. So again, you're on our website. This is everywhere. It's right here, but you do have to log in. Okay, once you log in, it'll take you to a section of information called eligibility, which I'm going to scroll down. Do an eligibility check. It will actually look like this, and you want the second portion on there because you do want to do an eligibility check. When you scroll down, you're going to stay in eligibility information, not supplemental, but straight in eligibility. You will see summary, Part A deductible, Part B deductible. You want Part A deductible. If, for instance, you were trying to see if they had a Medicare Advantage plan, therefore consolidated billing, throw it away for right now because they're in that. You can see here is the MA button, but it's all like grayed out. It doesn't look like anything. It's really light and hard to read. That's because this patient didn't have it. They don't have MA. But that's the button you would use. And we'll look at that in just a moment because there's another question related to that right after this one. So we're going to go to the Part A deductible. Scroll down again. The summary screen is just their available benefits for that particular year that you entered in. Here's their stuff that you got to know. The deductible contains what's currently relevant. The question relates to these three fields and why they do not always appear. These three fields are based on a claim having come in to start the spell dates, right? You can't have an earliest date if we don't even know that they're in a skilled nursing facility, and that is done through the claims system. So if you don't see any of those three fields, it means that patient does not have um, a claim on file with us for those dates. The issue is how a SNF bills versus how a professional bills, or in some cases, how other people bill. In this case, it would be the professional. Why is that important? Because a SNF cannot bill just at random cycles. A SNF bills admit to the first 30 days, then once that claim is submitted and processed, they can bill the next 30 days, the next 30 days, and the next 30 days. But if at any given time one of those claims gets stuck, they have to wait until that claim processes before they can bill. So let's put that into a real life factor. The patient is in for all of the month of January, so that's 31 days. They can bill on either January 30th, anytime after that, or January 31st for the entire month. The 30 days allows for a monthly billing. Typically, it's not billed on February 1st. We're going to drop that bill right now today. Can it be? Absolutely. Yep, it is eligible for that. However, it's not typical. So let's be a little bit more realistic. It gets billed on February 15th. Looks great, comes in, but all of a sudden the system says, stop, hold up. The patient's still there. Okay. But you can't bill February until it processes. We then request additional documentation. That takes 10 days to go out. 10 days. Now we're at the 25th of February. Are you guys seeing where I'm going with this? They send it back, but that takes 15 days. Well, now we're into March and we're beyond that. By the way, you're continuing as a Part B provider to provide services and bill those services because you're looking at the Part A deductible and you're like, hey, nothing there, man, not effective because the first claim hasn't processed yet because it's being developed on. Once that claim processes, the common working file will communicate back and say, hey, guess what? All of these claims that we processed, starting with our inpatient admission, cannot be paid. Take all that money back. So hopefully all of that makes sense. I tried to answer about four different questions in that little explanation. So if something isn't really fitting or you need a little bit more information, please put that back in chat. I know it was kind of a long explanation, but with the number of questions that I had, I wanted to make sure we got it addressed. Um, oh, the next question is the billing NPI. Where does the billing NPI come from? Sorry, read that wrong. Yeah, the billing NPI comes through the bill that comes in. So it's who's being paid for. Okay, who's being paid for? That's the SNF that's being paid for. The next question, this is actually a really good question. Patient comes into our ER and is in the ER. They're not inpatient, but they're in the ER over a midnight lapse. How does that work? Well, what happens is the skilled nursing facility has to bill a leave of absence. They didn't necessarily discharge them, and they know they're coming back from the ER, but it's literally over midnight. The skilled nursing facility will not be paid for the day they left the skilled nursing facility because they weren't there at 11:59 when the midnight toll rolled. So they're in the ER at 11:59, going to 12 o'clock. The day before the 11:59 day, the one that was the first one, they're not getting paid for that. So sometimes you say, well, wait, if we did this on this day and then we did a second one on this day, why does it apply here but not here? And it's because it was done, oh, wait, they were in the ER, but they had it done out of the ER setting, therefore it doesn't count as that. Oh my gosh, too much information. Just please remember that the skilled nursing facility is required to bill a leave of absence if the patient is not in their facility at 11:59 p.m. on that day. That day then becomes a leave of absence and they don't get paid. Therefore, consolidated billing does not apply. That's my summary of that question and the three or four caveats that the person added with it. So again, if I didn't quite hit what you needed there, please put some more information back in chat. I can get that done. Next question was super simple. Has anything changed? And the answer is nope. Just those CMS files going to 2026, and make sure you check for the current coding from the AMA and all of those different files that are used. Okay, this one is going to be interesting, and I'm going to have probably Leanne look up a quick YouTube for me. But how does consolidated billing apply to ambulance? First, it does not apply to a modifier 26 in TC, as ambulance do not bill those. Second, if the patient is going for something in an ER setting and it is billed appropriately, the ambulance would be excluded, just like major category 2 for an MRI or other things done in a hospital. They would all be excluded. However, if not, and it was done at a diagnostic center, then the ambulance would not be excluded because it would not fit the major category criteria. And that's part of what happens when you look at these particular codes. Remember the caveats that go with it. We do offer a video just on skilled nursing facility consolidated billing and ambulance. That video is quite complex. Oh, wait, I actually have the link right here. Never mind, I don't need Leanne to look it up. I'm going to put that in the chat for you right now. I do recommend that you take a look at that. I will tell you that we are going to do some more courses on that, including one specifically to ambulance, because it is a lot harder than just, hey, it is or is not included. There's a lot of caveats and stuff that go with it. All right, so I've talked a lot about the pre-submitted questions. I got through all of them. I want to know if we have any questions in the chat. Leanne, anything?
Tom, we do not have any questions in the chat at this time.
All right, well, I'm going to go ahead, go back to the PowerPoint. I'm going to close out then. So you're going to be given the opportunity to provide some feedback. Please do this. It's 5 basic questions, pretty quick. Leanne's going to put a link to the survey in the chat. We're also going to give you the opportunity when we close out of the webinar to go ahead and just go to the survey. It's going to give you a little pop-up box, looks like this external site, little triangle, and then the blue button on the bottom. The blue button says continue. If you select that, it'll take you directly to our website, directly to our survey website, which is listed as a destination site right here. So always look for CMS Mac Fed Ramp right there. That indicates that it is the CMS website that you're taking. The CMS survey that you're taking, again, this survey is for CMS. It does help us. We do look at it. We definitely want your feedback and give us what you can. So we really appreciate it if you would take that. Couple more things for the next 7 days. 7 days. I'm going to take any questions that you may have. For those of you that are new, definitely feel free to put anything you might want to know in there about consolidated billing. I'd be willing to do that for you. Here's what I need you to do. I need you to email us. For those of you that do have the chat available, check the chat. Leanne will throw the email and a subject line in there for you. For those of you that don't, you might need to take notes, so I'm going to go pretty slow here. The email is wps.gha.education, wps.gha.education at wp WPSIC. That is William, Paul, Sam, Isaac, Connor, WPSIC.com. Again, in the subject line, include something like SNF CB, Skilled Nursing Facility Consolidated Billing, SNF CB Modifier 26 TC. Just give me some heads up that it is about that. That way, anyone who's looking at that box can get that forwarded to me. I'll either email you back as an individual, I'll email you back as a group. Not sure. It just depends on the question that comes in. Want to remind everybody, we do offer consolidated billing on a fairly regular basis because it is a big topic. It's a lot that goes into it. So if this really wasn't the one that you needed, but you want to look at some of the other ones, do check our live events for more that are coming up. We typically post one a month, so you might not see any out there right now, but maybe next month we'll have something that might interest you. With that said, I'd like to thank you for attending. Thank you for your time. On behalf of myself, Leanne, and Ella, Provider Outreach Education, we hope to see you again in the future and to hear your questions and comments. Please don't forget to take that survey and let us know how we did. Let us know what we can do better and what we're doing well. You may now disconnect.